Thank you for the introduction. Good morning, or maybe good afternoon now, ladies and gentlemen, and thank you for the organizers for inviting me. I'm going to speak about prophylaxis in obstetrics, time to change. I think you heard a lot about these medications or interventions that I'm going to be talking about over the last couple of days, but maybe I'm just trying to put them together in the context of evidence-based, which is the context of the recent obstetric care. One of our very old friends in obstetrics is aspirin. And it's always like, we hate something and then we love it back and then we hate it again and we love it back. And this has been, the case with the aspirin. So from the early, late 70s, early 80s, there has been like a lot of interest in aspirin, and it started coming up in obstetric literature. And at that stage, they said that using aspirin based on the weight of the mother actually improves the pregnancy outcome and the pregnancy care. And then later on in the early 80s, they studied higher dose of aspirin that we currently use now. It's like 150. And at that stage, they said that using 150 milligrams of aspirin actually improves the pregnancy care with regards to the reduction in the risk of preeclampsia and intrauterine growth restriction. So, and then many years passed, and we were just using aspirin or not using aspirin till we actually started coming up with more evidence that tells us, do we actually benefit from using aspirin? So this is a meta-analysis for the use of aspirin or the low-dose aspirin at less than 16 weeks of gestation for the prevention of preeclampsia. And you can see that we actually have the risk of preeclampsia if we use low-dose aspirin before 16 weeks of gestation. So this is documented now. How about intrauterine growth restriction? Again, the same thing. There is a definite improvement in the pregnancy outcome with regards to intrauterine growth restriction if we use low-dose aspirin, again, before 16 weeks of gestation. If we use it before 16 weeks of gestation, then the relative risk for preeclampsia is 0.5, for severe preeclampsia is 0.4, and for fetal growth restriction is 0.5. So this is if we use it before 16 weeks of gestation, and studies have shown that higher doses of aspirin, still within the low-dose aspirin regimen, actually improves the pregnancy outcome. So if you use it before 16 weeks, then maybe you can consider using a bit higher dose of aspirin, between 80 all the way up to 150, especially in the high-risk population. If you only start using aspirin after 16 weeks of gestation, the reduction in preeclampsia or severe preeclampsia is not as profound as that when you use it before 16 weeks, and the dose at that stage doesn't really make much difference because already, the effect is really not as good as that when you use it before 16 weeks of gestation. So there was really no relationship to the dose if you use it after 16 weeks, but there's a clear relationship to the dose if you use it before 16 weeks of gestation. Okay, who shall we give aspirin? Do we give it to everybody? We know that there are patients who are at higher risk of developing pregnancy complications like preeclampsia and intrauterine growth restriction. If you look into the ECHO guideline for the hypertension in 2013, they have put all these indications or risk patients for the development of preeclampsia. So do we give it to everybody? Do we give it to everybody with diabetes? Do we give it to every mother who is a bit on the obese side? So it's a difficult decision. Who do we give it to? And remember, whenever you give a medication to everybody, then the overall effect of that medication is really not going to be as profound as when you give it to the high-risk population. But definitely, if you give it to somebody with a previous history of early onset preeclampsia or previous history of severe preeclampsia, then these patients will have a very high recurrence rate, and therefore it's probably cost-effective to use aspirin. So let's look into the numbers needed to treat for aspirin. For preeclampsia, you need to treat 56 women with low-dose aspirin to prevent one case of preeclampsia. You need 50 for preterm delivery at less than 34 weeks, and you need 40 for pregnancy with severe adverse outcome. So it is effective. But do we actually give it to everybody? This is, again, we go back to the question. Okay, it's effective if you give it to the high-risk population, but if you give it to everybody, do not underestimate the risk of actually having vaginal bleeding and maybe like other problems that the patient might, suffer from, like bruising, like maybe gum bleeding. So you're actually maybe increasing the risk. They might be minor things, but vaginal bleeding is not minor. And patients really panic. The health system gets like overloaded with patients presenting. So you always have to think, shall I actually be using it to everybody or just use it to the high-risk population? So the conclusion for the use of aspirin is that it needs to be used for the high-risk population. How do we identify the high-risk population? You might be wanting to use like screening methods, definitely somebody with a previous history, and the recommendation is if you know that this patient has more than 1% risk of developing preeclampsia, then this is somebody that you want to consider giving them low-dose aspirin. Start with a dose at least 80 or 81, depending on the tablets that you have, because lower than that, 75 to 80, you'll find a lot of patients who are actually resistant to aspirin, so they're not going to benefit from your low dose. And definitely consider doses as high as 150 in much higher risk populations, especially somebody, for example, with multiple previous preeclampsia, who were on lower doses of aspirin with the previous pregnancy and did not actually work in reducing the risk of preeclampsia in the subsequent pregnancy. So we'll move to something else. Antibiotic for preterm labor. We heard earlier this morning that using antibiotics for patients with ruptured membranes is evidence-based, and this is, I'm sure most of the people will actually give antibiotic for patients who present especially with preterm premature rupture of membranes. How about antibiotics for patients just presenting in preterm labor? And again, there was like a lot of talks and a lot of people still give antibiotics for patients, but what is the evidence? Why are we giving antibiotics? Are we giving it to delay labor for somebody who, because we think that preterm labor might be related to infection? It doesn't. So there is really no benefit. And if you look there is no evidence that antibiotics for just pure preterm labor without ruptured membranes is of any benefit. Okay, perinatal mortality. Are we reducing perinatal mortality? We are not, and maybe there's even a tendency to increase perinatal mortality with the use of antibiotics. So there is no evidence for antibiotics for perinatal mortality. Neonatal death, again, there is no evidence, and there's a tendency for increased morbidity, increased mortality with the use of antibiotics in patients with preterm labor. Yes, of course, antibiotics is going to reduce your risk of maternal infection, but if it's not improving the other pregnancy outcomes, so maybe this is a small indication for the use of antibiotics. Major cerebral abnormality, there is no improvement because, again, I mentioned that, and maybe preterm labor is because of an infection, and we heard earlier that chorioamnionitis increases the risk of neurodevelopmental handicap and all these problems, but unless you have documented infection or you have documented ruptured membranes, it does not help. Any permanent impairment at 7 years of age, again, there is no evidence that it actually improves, it might actually worsen it. And cerebral palsy at 7 years, there is no improvement, and there's a tendency for increasing the complication. So no antibiotics for preterm labor without ruptured membranes. But remember, I don't know if you read this recent recommendation from the Royal College that just came out now, September 2017, with regards to GBS, because in the UK there is no routine screening for GBS as far as I know, but if a patient presents with preterm labor, then it is recommended to actually give her antibiotics, regardless of even if we don't know the GBS status or whatever screening she had before was negative. So preterm labor at less than 37 weeks, it is recommended to give them antibiotics. Again, obviously, with the other indications for GBS prophylaxis, which we know, which is if she has positive GBS, ruptured membranes, prolonged ruptured membranes more than 18 hours or whatever. But just preterm labor, at less than 37 weeks, there is new evidence now to say that these will benefit from using prophylactic antibiotic. Okay? We'll switch gears to something again, one of our friends, and we heard a lot about progesterone, and it's like one of the newest additions to our obstetric care over the last few years. Although, maybe 10, 12 years ago, we used to say, why are you using progesterone for these patients? There is no evidence to support that. And now we're going again into loving progesterone to the extent that everybody is using progesterone. So what is the evidence? First of all, how does progesterone work? We know that in early pregnancy, especially in IVF pregnancies or ovulation induction, we know that there is insufficient corpus luteum, and therefore we use it to support the corpus luteum till the placenta takes over the action and starts producing its own progesterone. But later on in pregnancy, progesterone has been definitely proven to actually make the uterus quieter, and it reduces the apoptosis in the membranes, and therefore it reduces the risk of rupturing the membranes, which again is a positive when we are dealing with patients at high risk of preterm delivery. In addition to its effect on the progesterone, on the natural progesterone receptors, so it improves, the presence of the natural progesterone receptors, and therefore makes the effect of the natural progesterone even better. So who do we give it to? Do we give it to everybody? Again, studies started in 2003 looking into progesterone for patients with a previous singleton preterm labor and a previous pregnancy. And in this study, they looked into 450 women with previous preterm delivery at less than 37 weeks, and they used IM progesterone at that stage. And they showed that delivery at less than 37 weeks, less than 35 weeks, and less than 32 weeks was actually reduced with relative risks between 40 to 50% reduction. So it seems to be effective. And because we all had a worry about progesterone, does it actually cause virilization? And they have proven that no, it does not cause any virilization of the female fetus. So that's where the interest in progesterone for the prevention or the reduction in the risk of preterm delivery in somebody who had a previous preterm delivery. Another study that was Cochrane database review that was done in 2013, and again confirmed what these different studies have shown, and it showed that the birth at less than 34, 37, and even neonatal morbidities and mortalities were actually reduced by the use of progesterone for patients with previous preterm delivery. Then came the optimum study, and the optimum study, if you look in the inclusion criteria, they looked into preterm delivery, which the previous meta-analysis of the Cochrane had looked into, but that's not the only inclusion criteria. They looked into a variety of other risk patients that we know that there might be at a higher risk of developing or delivering preterm, such as a short cervix in the current pregnancy, a positive fetal fibronectin. So it was basically a combination of different patients, all yes with increased risk, but they are really like apples and bananas and oranges and everything together. And no surprise, once you do that, then your effectiveness of the treatment is going to be actually different, or it's going to be maybe biased. So therefore, at that stage, they said that no, progesterone is not really effective for the prevention of preterm delivery in these categories of patients. Although the same study, they mentioned that neonatal morbidities were actually, even neonatal death was actually reduced. And when they did sub-analysis for the specific patients with the previous preterm, they found that it's actually effective. So again, meta-analysis, that's what we always do in medicine. We bring all the studies together, and this meta-analysis in 2016, which included the optimal study, and again confirmed that if you actually use it, not only now for the patients with the preterm delivery, but the patients specifically with a short cervix in this current pregnancy, you will actually improve their pregnancy outcome, and the delivery at less than 34 weeks, less than 28 weeks, is all reduced by maybe 40 to 50%. So even patients with a short cervix in the current pregnancy will benefit from progesterone. So singleton, previous preterm delivery, singleton with a current pregnancy with a short cervix less than 25 millimeter will benefit from progesterone. How about multiple pregnancy? How about twins? Will twin benefit the same? I mean, we know that they are high risk, so why don't we give progesterone for all twins? And earlier meta-analysis that was conducted in 2015 said that there is actually no benefit, whether you give them IM or you give them vaginal progesterone, so there is no benefit. And that's why people started shying away from using progesterone for unselected twins. How about twins with a previous preterm delivery? Nobody actually knows because there is no studies that were conducted on twins with previous preterm delivery, so we don't know. But why should they be different? I mean, if she had a previous preterm delivery and she's currently singleton, we will give her progesterone. But if she's currently twins, we don't give her progesterone. I don't know what's the logic, but there was no studies basically, so we can't really answer that by evidence. Till the study that was published in 2017 by Professor Nicolaides and Roberto Romero, and they looked into vaginal progesterone meta-analysis for the reduction in the term of preterm delivery in multiple pregnancies, and they have confirmed that it actually works. So even for multiple pregnancies with a short cervix, so we're not talking about unselected multiple pregnancies, only multiple pregnancies with a short cervix, less than 25 millimeter, because this is usually the cutoff that we use for the high-risk population, they will benefit from vaginal progesterone. And this is maybe what people are practicing nowadays, and the numbers needed to treat are actually quite impressive. I mean, 9, 10, something like that. So you do actually reduce the risk of preterm delivery in the subpopulation of patients with a short cervix and multiple pregnancy in the current, and multiple pregnancy in this current pregnancy. So what type of progesterone? Which one should we use? Should we use the IM? Should we use the oral? Should we use the vaginal? Oral hasn't really been proven to be effective, so it's really not one of, it hasn't been studied properly, so we don't actually use it just for the prevention of preterm delivery. But the IM, people would recommend that you use the IM for patients who had a previous preterm delivery, just because you really wanted to work on reducing the contractions, while you use the vaginal progesterone for patients who have a short cervix, because you want the effect to be more local on the cervix. But again, there is no strong data that will tell you this is definitely what you should be doing, but this is the recommendation. And this is FDA approved, so prior spontaneous preterm delivery, yes, IM progesterone, cervical shortening, yes, but it's not FDA approved, but it's vaginal progesterone. And remember that, we usually used to say that if she had a previous preterm delivery because of multiple pregnancy and now she is singleton, well, we don't count that previous preterm delivery because she had the preterm delivery because of the multiples, not because she actually has a higher risk of preterm delivery. Most of the recent data will tell you now that no, you should consider a previous preterm delivery, regardless whether it was singleton or multiples, as a preterm delivery. So if she comes pregnant again this time, consider her as if she had a previous preterm delivery, and then consider starting progesterone as appropriate. How about progesterone for preventing miscarriages? I'm not going to talk much about it, but the Cochrane database does not support the use of progesterone for the prevention of miscarriages, but maybe patients with recurrent miscarriage, although again, there is really no strong data to support that. So previous spontaneous preterm birth, yes. Short cervix in the current pregnancy, yes. Twins with short cervix, yes. Unselected twins, no. Recurrent miscarriage, no. And twin with previous spontaneous, there is birth. There is no evidence, but I don't know. Maybe yes. Okay, the last thing I'm going to talk about is anticoagulation. And we just heard an excellent lecture earlier this morning about anticoagulation and thrombophilia and recurrent miscarriages, and where is the data nowadays? Do we actually test or we don't test for thrombophilia with recurrent miscarriage? There is a lot of talks about it recently, but classically, patients with thrombophilia and recurrent miscarriage, many studies have proven that they will actually benefit from using aspirin and anticoagulation. So this is most of the people, this is what they will do. How about unexplained pregnancy loss? Does that apply to patients with unexplained pregnancy loss? And there are many data that will tell you that no, it does not. This is the SPIN study, which looked into, it's a randomized controlled study of low molecular weight heparin and low dose aspirin for patients with recurrent miscarriage. And they enrolled patients, almost 300 patients, with 2 or more previous consecutive preterm delivery, and this was published in 2010. And they said that there is actually no statistical improvement in the pregnancy outcome if you give them anticoagulation, if they are just unexplained, after they have been worked up, obviously, they are unexplained recurrent pregnancy loss. And again, don't forget, the same applies to anticoagulation. Anticoagulation causes bleeding. And is it justifiable to increase her risk of vaginal bleeding, antepartum hemorrhage, nosebleeds, all these things? And obviously, this is all associated with extra need for care. You know, your insurance companies are not going to be very happy about it. Is it justifiable to do that for patients where there is no evidence to support the use of anticoagulation? We need to think about that before we actually give anticoagulation for patients with recurrent pregnancy loss. Another study, the ALIVE study, again, their conclusion was neither aspirin combined with anticoagulation or aspirin alone actually improves the live birth rate in patients with unexplained recurrent pregnancy loss. So again, there is no support for that. Even for another study that was published by hematologists, and I agree with what was said earlier this morning, that most of these patients, they go to hematology because they actually have already problems, but if you just come to the pure recurrent pregnancy loss without any other problems, there is no benefit from adding anticoagulation. And this is that there is no improvement in the pregnancy outcome. So there is really no place for anticoagulations for patients with idiopathic recurrent pregnancy loss. But unfortunately, this is, I don't know if it's the same here in, where the audience are practicing, but sure it's the case in Saudi Arabia where patients will come to you, primely gravida, no risk factors whatsoever. And she's on aspirin, she's on heparin, on steroids. Now this is like our new friend. I don't know where they came up with the steroids, and progesterone. So really no evidence for the use of these medications. So I hope people start practicing more evidence-based medicine and look into things that we have been doing classically and look to it from another aspect. Thank you very much.